dear colleagues and enthusiasts. I'm Dr. Irene Akideno. I'm the Vice President and the Chair of the Education Committee. Today, we have the 32nd series of our bi-monthly webinar. And today, we would be having a discussion, a presentation on eye care in the critically ill. These are things that sometimes an aspect that we overlook, times in the ICU, in the critically ill patient. So I welcome you all, and thank you for making out time on your Sunday evening when you should be relaxing with family before the working week starts, to spend about an hour with us. So we sincerely appreciate your love for the I-CCSN and for knowledge gain and sharing. And today we have a very distinguished speaker who is one of us in diaspora. And then we understand with the time zone, it's about midday or around 11 or so in some parts of the United States. But she has, because of her passion, she has accepted to be a presenter, Dr. Eniolami Dosunmu. I will, Mr. President, to give a word of welcome to you, Mr. President. Mr. President.
Yep. We're starting. Hello.
Yes, I've handed over
everyone.
To you for your welcome.
Yeah, good evening, everyone. I must sincerely thank Dr. Eniolami Dosunmu for taking this initiative to talk to us today. Thank you very much for sparing this time. If you're busy doing something else, it's a topic that is very dear to us. On the surface, people take it for granted, but from literature, it's very obvious that, like some books who said 40% of patients who are admitted in the ICU end up with ocular surface diseases. So we don't have, I'm sure there's no literature backing it up from Nigeria because we overlook it. So we are grateful to have you talk to us. And then for everyone who is here, I send my special regards to very senior colleagues like Professor Fakonle, who is the faculty chair for the Faculty of Anesthesia at the West African College of Surgeons, and very other prominent colleagues and senior colleagues, our teachers and trainers who are here. May we spare her this time to talk to us, and I'm sure at the end of the day, we'll learn one or two things that will serve as one of the guidelines. These days now, we're developing guidelines for several procedures, several aspects of care in critical care medicine. I'm sure that is rarely, I'm sure we've not really had the privilege to have a guideline on ocular care in the critically ill in Nigeria. We don't have such. So today, at the end of today, I'm sure we'll have one. So it's imperative for everyone to listen carefully and spare your questions at the end of the section. Thank you very much. Thank you very much, and welcome everyone to this section. I hand over back to the Vice President and then the moderator.
Well, I don't think the Vice President is there to come up. I think.
Thank you so much, Mr. President. Dr. Joe Botok. This is Dr. I'm here.
Okay.
Okay, I think we should go ahead with the biography because I think she has issues with her network.
All right. Thank you, Mr. President. Good evening, our elders, chiefs, and colleagues. You're welcome to this very interesting webinar on eye care in the critically ill. My name is Dr. Rosemary Nwokorie. And just before I go ahead and introduce the speaker, I would just like to remind us of some ground rules. I expect that our microphones should be muted to enable us to have a very clear conversation and discussion. And then if you have comments, it can be made at any time in the chat box. Please keep it professional and respectful. The opportunity to ask questions will be given at the end of the webinar. Those that want to ask can go ahead, and those that want to post in the comment box can also do so. And I'm sure that the speaker will respond appropriately. A gentle reminder also to rename your devices so that we can know who we are dealing with at any point, and also notes in the attendance. Thank you very much. And it's my pleasure to introduce to us our speaker for today's webinar, Dr. Eniolami Dosunmu. Dr. Eniolami Dosunmu is an associate professor of pediatric ophthalmology and strabismus at Abrahamson Pediatric Eye Institute, Department of Ophthalmology, Cincinnati Children's Hospital Medical Center, University of Cincinnati. She's a multiple award winner in clinical practice and academics and has about 19 peer-reviewed publications. She also serves as a peer reviewer for some journals, including Ophthalmic Genetics and International Ophthalmology. Dr. Eniolami Dosunmu has contributed chapters in about 5 books and has made about 14 scientific presentations at international conferences till date. Time would not permit me to deal extensively with Dr. Dosunmu's very impressive CV, but consider it my pleasure on behalf of the Critical Care Society to welcome you as speaker at this webinar. Thank you very much. You have the floor, ma'am.
Thank you so much. Good evening, everyone. Good evening to our elders, to our chiefs, to the Intensive and Critical Care Society of Nigeria, and thank you so much for this wonderful invitation to speak with you. I'm very grateful. I will go ahead and get started because I know we have 40 minutes. Please, anytime during this, if I'm going too fast, you want me to go back, please don't hesitate to jump in. Otherwise, I'm not going to be able to keep a track of the chat while I'm presenting, but please, if anything is needed, I'm happy to go back. Thank you again. So I'm just going to start by going over a little bit of the anatomy of the eye, just to orient us, and please forgive me if any of this is redundant information. So in the front and the top photo, you can see just the external photo of the eye showing the pupil, the eyelid, the sclera, where the tear ducts are. We'll be referencing some of those, but the most important one that we'll reference a lot is this front surface of the eye, the cornea, and the conjunctiva. And then we'll also talk a little bit about the back of the eye. This is a color fundus photo demonstrating the back of the eye, in particular the distinct optic nerve margins and where we get our best vision, which is the fovea. Between these arcades is what we call our macula. I will reference these photos again in the future. So just to give us a layout of how we're going to talk about everything, these are not breakdowns that people have agreed to, but this is how I think about things when I think about the ICU setting. I think about them as secondary, thus the reason I put them in quotes, ophthalmic findings, meaning that the patient wasn't there for that reason, but in the setting of ICU care, those might arise from an eye finding. We'll really talk about the pupil exam because not only does it give you ophthalmic finding, it can give you findings that explain why a patient may or may not be in the ICU or what else we may need to do for care. And then primary, meaning that these are things that show up directly in the eye, may be associated with other reasons the patient is in the ICU, but they're primary findings. So starting with the secondary, because those are the most critical, and as Mr. President has said, most necessary for treatment. I will talk about exposure keratopathy first and really spend a significant amount of time talking about this. So most of our ICU patients, they're intubated versus some other form of mechanical ventilation, either that be CPAP or BiPAP or or if they're trached, they're getting some form of ventilation, most ICU patients. Most are sedated, most have neuromuscular relaxation on board, so that really prevents them from blinking, from closing their eyes. Those states have been sedated and And having neuromuscular relaxation decreases some of the reflexes we have in the eyes. And then, of course, the other comorbidity or comorbidities that led to the ICU admission are also at play. So a lot of our patients may have hypertensive crisis or third spacing of fluids or metabolic imbalances, and all those other things also will affect how the ocular surface and in general how the organ, the eye, functions. So, what happens in exposure keratopathy? It really is a breakdown of the ocular surface. So, in that setting, if there's loss of the blink reflex, again, our patients are sedated, neuromuscular relaxed, they're not making the tear production because that reflex that would ordinarily be there is decreased or absent. Patients don't fully close their eyes, especially when they've been in the ICU for multiple days to multiple weeks, and in some cases to multiple months. So that can lead to dryness of the ocular surface, and then that can lead to scratches on the ocular surface, and then that can lead to infections on the ocular surface. And if those are not treated appropriately or caught in time, that can lead to scarring of the ocular surface. And the ocular surface is very particular. And so the collagen that makes the cornea and gives us that beautiful clarity every time there's an infection or breakdown in the surface, when it starts to grow back after an infection, instead of laying down this really nice collagen that allows us as humans to see through the cornea, it comes in a haphazard pattern, and that creates a scar, and that can lead to permanent vision loss, which we all don't want for our patients. So this is a photo from actually an article that was talking about in particular ICU care, and it's demonstrating this is fluorescent staining, but all those spots that are lighting up across the cornea, more the inferior portion, and across the conjunctiva are all consistent with dryness. And so this patient was stained with fluorescein. I really like the fact that it's really showing down below, because that's what happens. Most patients can close their eyes and over time not fully close their eyes. So you tend to see this on the inferior portion of the cornea, in particular the ocular surface. This is not the same patient in the ICU. This is another patient I've had the privilege of taking care of, but this demonstrates a corneal abrasion. And as you can see, all those dry spots, if they stay in place and they keep coalescing and getting bigger, it can lead to a huge corneal abrasion. And as you can tell, this has taken up a significant portion of the ocular surface. The other thing to talk about quickly about corneal abrasions is we have more nerve endings on our corneal surface than we have if we think about it even on our fingers, and we can usually feel a pinprick in patients who don't have neuropathy on a finger. And if you think about the fact that that's an exponentially higher number of nerve endings on the cornea, that can be very painful. However, most of our ICU patients cannot tell you or cannot report pain because they're usually neurologically decreased, secondary to either iatrogenic reasons, or we did it in particular because we needed to, or secondary to what brought them into the ICU. Mr. President was saying that keratopathy is really high. And yes, depends on which literature you read. It can be from 10% to 60%. There was one paper out of Nigeria that I was able to find that put that incident at a higher level. But of course, that was from several years ago. And likely, we're all hopeful that this number is significantly lower. A lot of papers, and a lot of them are listed here below, who over time have protocolized how to treat ocular surface in the ICU, have found that doing so can even decrease that incidence to as little or as low as 3%. So I'm hopeful that, like Mr. President has said, we can create a protocol to really decrease the incidence for our patients. This is taken from one of the aforementioned papers, and this is the protocol they use, not necessarily the protocol everybody has to use, but I particularly liked it because it was really looking at risk factors, like the patient is ventilated, are they sedated, are they blinking, or are they ventilated but able to blink and, at least communicate. And
Sorry, please.
yes,
Dr. Dosunmu, please
yes, ma'am.
could the slide itself be the main one, because we can't really see the slide. It splits between yourself and the slide. So if you can make the slide the main
Absolutely. I don't know why
display.
Zoom is
Yeah.
doing that. I'm going to stop
Is it
sharing and then
possible?
maybe, yes, I will
Okay.
do that. I will stop sharing. And
Okay.
yeah, I just saw the chat. Let me stop sharing and go back
Okay.
in and see if it's something with the
Okay.
setting for
Okay.
sharing. Sorry about that, everyone.
Thank you very much.
Let's try that again. How does this look to everybody?
Yeah. Oh, perfect. Thank
Wonderful.
you very
I
much.
think it was something in the Zoom settings. It was sharing it, splitting like the presenter and
Okay.
the slides. So I
And
will go
okay.
back. Can
Thank
you guys see this properly?
you. Yes.
Do you need me to
Yes.
go back to any other previous slides?
No, I think we can go on with this.
Okay, very
Thank
good.
you.
Thank you. All right. And so this particular paper, I liked their protocol, or I think, at least I think it's a good protocol on which to build on. They talk about having an eye assessment at least every 8 hours. Um, in the United States, most of the nursing staff switch out every 8 hours. Every hospital system is different, but that's really a good time, sort of like the nursing staff or the caregivers are coming on board and they can do this. And then, the patients who are alert and blinking don't get anything. The ones whose eyes are open, they get a really more intensive eye lubrication schedule. So, and when they looked at their patients, they looked at them pre-initiation of protocol and post-initiation of protocol. And that's when they found that they could decrease that incidence to a lot less than 10%. So really the way to treat exposure keratopathy is lubrication, lubrication, lubrication. Some of the papers that have come out of sub-Saharan Africa have talked about doing saline. The problem with saline is it truly doesn't mimic what our tears are because our tears are a mixture of water, lipid, and mucin. So saline is just salt and water, and what that would do is just evaporate things. So the lubrication needs to either mimic tears, but in a patient who's not blinking frequently, you actually want something thicker, and oftentimes ointment, which or if oil-based, which is usually the preference, then serves as a barrier across the entire ocular surface and then helps to trap in moisture instead of serving as a conduit for additional evaporative measures of moisture. Eyelid closure. Sometimes you can just do something as simple as taking some surgical tape and taping the eyelids closed. For patients who are in the hospitals for a prolonged period of time, ophthalmology can come in and then temporarily suture the eyelids closed, or in some cases, permanently suture the eyelid closed, depending on multiple different factors at play. We can put moisture chambers, which trap moisture in for patients. Antimicrobials, certainly if there's a keratitis. Sometimes you can use a bandage contact lens, being careful that you'd have to replace it and cover antimicrobials versus a scleral contact lens. So the scleral contact lens looks like a bowl, so there's fluid in it. And that way, when the contact is on the eye, the fluid constantly bathes the surface of the eye. Punctal plugs decrease drainage of tears from the surface of the eyes, not evaporative measures, decrease drainage. However, that's not the primary thing. It's more of an adjunctive treatment if you've maximized others. And of course, always contacting ophthalmology in terms of evaluating the patients for other comorbidities or other pre-existing ocular surface disease that may be exacerbated in the setting of the ICU. So, my recommendation is really to institute a protocol, as Mr. President has said, where you assess the risk factors and for this protocol to be scheduled. You look for evidence of exposure, you look at the eyelid position, you look at what the ventilation looks like. Do you have a CPAP that's also blowing air up into the eyes, or are you intubated with very little exposure going to the eyes from the mechanical ventilation with good closed eyelids, and then really looking at the reason for the ICU admission. Is this patient third spacing, or does this patient have other things that are leading to other ocular surface diseases that put them at risk? Lubricate, 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 close the eyes, and keep repeating the assessments on a scheduled basis so that we can escalate treatment in a timely manner. Of course, partnership with ophthalmology and with our nursing staff, very important. And hopefully we can measure our outcomes so that we can keep getting better and better. So, in my opinion, the best treatment is really pre-recognition and prevention so that then we know early and screening for risk factors. Other things that you can see in the ICU that are not only exposure keratopathy is a conjunctivitis and a keratitis. So inflammation and infection of the conjunctiva and of the cornea. These photos show what an ulcer looks like. And in the top photo, there's also a hypopion, so the infection has moved into the front area of the eye. Another reason for continued screening of the eye, so that if we notice a patient has this who is not verbal, it can be treated quickly before the infection spreads and, God forbid, there's permanent vision loss. Oftentimes in the ICU, if there's not if there's dryness on the surface, the other ways that this can happen is just even suction in the airway. If the patient has got a pneumonia or something, just those aspirates can then sit or get introduced to that ocular surface, and in that setting, then infection can occur. Chemosis, when we talked about third spacing, or if there are orbital findings, or if there are facial fractures, or if there's orbital congestion, it can happen in that setting of that mechanical ventilation. That high positive pressure can push things on. And as you can see, the eyes, every time we close and we blink, our eyelids ideally should just oppose the surface of the cornea and the conjunctiva, and that's when it brings, our tears there. However, in a patient like this with chemosis, when that eyelid closes, there's going to be a gap, and you're not getting that liquid and that fluid to the surface of the eye. So if this patient isn't recognized or treated, they can certainly get exposure keratopathy in that setting, even if the eye's closed, because then they've got pockets of air that's sitting over the cornea or over the conjunctiva, leading to dryness, which can then lead to other issues. Subconjunctival hemorrhages can happen as well in the ICU setting, again, from mechanical ventilation. Also, sometimes if you have to resuscitate a patient from that pressure that we're putting, if we're doing cardiopulmonary resuscitation, that can happen. Most, not all, are generally benign. However, some do need investigation, especially if the patient is also there for a clotting reason and is on anticoagulants, and if the subconjunctival hemorrhage is completely out of control and then becomes chemotic and very big and boggy, whether or not there needs to be any other interventions. Orbital emphysema is very rare. It's really when you push air into the orbit. Oftentimes, this happens in conjunction with an orbital fracture. That way, air can get up there, but really high, mechanical ventilation can also cause this to occur. I know that this group that I'm speaking with really focuses on adults, but I felt that it would be a good time I don't have any other slides outside of this to talk about retinopathy of prematurity, using my breakdown and algorithm of how I think about things in the ICU. This happens in neonates, and it is a primary and secondary in my mind because the prematurity puts the child at risk, but also the mechanical ventilation and the high oxygen setting puts the child at risk. So for those taking care of babies, it's really important to screen for them and to be certain to bring ophthalmology in to check the babies. Oftentimes, I quote the criteria we use here in the United States, babies who are born prior to 30 weeks or babies who are less than 1,500 grams. The criteria in Nigeria is different, and I know that the pediatric group of ophthalmologists and also ophthalmology has been working to create a protocol, but really being mindful that premature babies, even those in Nigeria older than 30 weeks, still sometimes need screening because this is leading to irreversible vision loss for those babies. I can take a pause here and see if there are any quick questions. I'm being mindful of time because we have 40 minutes and we have about 16 more minutes.
I think you can go on, please.
Very
It's
good.
really interesting. Okay.
Very good. All right. So the next thing that I'm going to talk about is the pupil. And the reason I want to talk about the pupil is the pupil exam is very critical for us in ophthalmology, but I believe it's very critical for everybody who does medicine because the pupils not only tell us about the eye itself, they also tell us about the brain, as the eye is an evagination and comes out of the brain. And so, especially for the ICU patient, I think about it like, well, that is another way for me to know what may be going on in the brain or what may be going on in the body of this patient. And so, outside of the protocol that we talked about for checking the ocular surface, having a protocol to check the pupils is also really critical, in my opinion, for the ICU patient who is sedated, intubated, neuromuscularly blocked for a long period of time. So really, when we do a pupil exam, we're shining a flashlight and we're going back and forth. So ideally, if I was doing a pupil exam on myself, which of course I cannot do, but I would shine the light in my right eye and I would check to see if I had a pupil reflex in the right eye. So ideally, the pupil would be bigger. If the light comes in, it would get smaller. And then I would shine the light in the left and I would also see big pupil get smaller. That's normal. And that you can see in rows 2 and 3. And then what you would then do is called a swinging flashlight, where you would go from one eye to the other. And you're also looking to see what happens to the pupils when you go back and forth in the eye that you're shining the light in, and also sometimes in the opposite eye. This down here demonstrates what would happen with a near target. I really just like the pictographical representation of this. Shine light in this right eye, both eyes constrict. Shine light in the left eye, both eyes constrict. This is a normal response. The near target is also a normal response, but our ICU patient is likely not sitting up and reading or looking at something for us to be able to do this particular test. This I liked because this shows what we call a relative afferent pupillary defect. And what happens is if there's something in the visual pathway, oftentimes in the optic nerve, but sometimes it can be along the visual pathway that is limiting how well an eye sees or functions, you would get a relative pupillary defect. So here in the top row, we're not shining light. Here we shine light and both eyes go down. Here you shine light in one eye. So the left eye here is normal. You shine light in the left, both eyes go down. Here you shine light in the right. And instead of the pupil constricting, you just find that it actually gets a little bigger. So when you're doing that swing flashlight test, and that's usually a sign that there's something else going on in the eye, which may mean something is going on in the brain, depending on what is found. And usually that should suggest that you should get an ophthalmology evaluation, and depending on what's found, maybe a neurology to come on board to also help in that patient's management. I particularly liked this paper. I read the summary, but I only went to the part. It's a paper by someone that talks about what to look for when you're evaluating the patient neurologically who's comatose. And it talks about air reflexes and all the other reflexes, but I really liked where I talked about the pupil exam. So I'm not going into an in-depth neuro-ophthalmic finding, but what I really liked here is, it's showing you that fixed and unilaterally fixed and dilated pupil, which would be suggestive of a midbrain injury or cranial nerve 3 injury. It's showing you what you would find if you've had a brainstem injury. It's showing you what may be a normal response, but should be evaluated. And so I really like this, and I would highly recommend if you can pick up the paper to do so, or just grab another review of this, and just as a review for the patients in the ICU. As they say, the eyes are the window to the body, right? I know they say the soul, but I also say to the body. All right, so moving on to the primary ophthalmic findings, the way I categorize things. So these are things that you would see directly in the eye, and there are reasons that the patient may be in the ICU for eye findings, in addition to probably other systemic findings. But sometimes you may have a patient who had trauma, maybe a motor vehicle accident, has eye findings in addition to other findings that lead them to the ICU. Chemical exposures, metabolic disorders that can also show up in the eyes, but you have a primary eye finding as well. So one example, when we talk about trauma, open globe injuries, what that means is there is a break in the wall of the eye. That is for us an emergency. Our goal is to close that eyeball, usually within 2 hours of the injury. Other things are orbital fractures. Some may be very small and not need treatment. Some may be larger and entrap the extraocular muscles. And so patient may end up in your ICU because they come in The eye looks white and quiet. However, every time they look a certain direction, they may drop their heart rate, get vasovagal, and pass out. That may be suggestive that they've actually entrapped one of the muscles and it's getting tight. They're getting vasovagal, and then that may need imaging and may need us to go and move that muscle out of that entrapment. You can have eyelid and facial lacerations. Oftentimes, that may suggest looking deeper in the brain to make sure that the force that could generate such eyelid and facial lacerations also didn't result in intracranial injuries. A retrobulbar hemorrhage is a surgical emergency for us. We don't want any other intracranial changes that may not be obvious that may show up with the eyes, such as optic nerve swelling or retinal hemorrhages or possibly optic nerve transections, facial fractures, other skull fractures, such as skull base fractures. Sometimes you can see changes. See if it'll let me move forward. So usually we talk about getting neuroimaging, getting ophthalmology on board, and again, going back to that pupil exam because you really would tell us what else to look for and who else to bring on board. So this is a CT from a patient I had the opportunity to take care of, and everything looks relatively fine up until the fact that you see this radiolucent opacity in the back of the eye. So unfortunately, this patient was a younger one who was playing with a BB gun with some friends, and a friend shot the patient in the eye. And so they came in and the eye was really bloody everywhere and was hard to see really, but we could see an entrance wound. And so imaging did demonstrate to us that that was truly an intraocular foreign body that needed us to go in. But because it was a gunshot injury, which is how it came in through the ambulance, also we had the ICU ready and waiting when the patient arrived via ambulance because even though it's a BB gun, anything that's categorized as a gunshot injury rises to the level of ICU. This patient, you can see that they've got facial fractures and the eyeball is really small. So this is definitely some form of an open globe in this patient. And in this one, they have they've got retrobulbar hemorrhage from the trauma that led to them needing this. And so this is an emergency for us in order to open up the lateral canthus and relieve the pressure. Otherwise, it could lead to permanent vision loss. I'm going to pause now and say that I do have a lot more eye photos in this part of it, really focusing more on the eye things you could see. Please be mindful, some people get very queasy with seeing eye things, so take the time. If something is too strong, just look away from the image. Other things you can see, we talked about eyelid lacerations and abrasions. You can see contusions. We've already talked about conjunctival and corneal abrasions. Important are hyphemas, which is bleeding in the front part of the eye. Oftentimes anything that can break blood vessels in the front of the eye. You want to check for orbital injuries all around, and you want to check to see if that's transmitted into intracranial. And then a couple other things that ophthalmology can see would be iritis and other forms of inflammation. Sometimes things you can see just using a direct ophthalmoscope would be you would see either the lens has moved when you look for a red reflex, or the lens is completely opacified when you're looking for a red reflex or even doing a pupil examination. Sometimes you can also have a dull or absent reflex if there's vitreous hemorrhage bleeding in the back of the eye or retina. I bring those things up when you think about the ICU patient because, for example, if you had a diabetic patient who had complete poor control, and let's say we brought in a 20-year-old who had type 1 diabetes but had been poorly controlled, hemoglobin A1C of 14, so making it very extreme. They've had diabetes for more than 5 years, type 1, and you don't get a reflex. That's really a call to us in ophthalmology. So it's not a primary per se, but still it's a call to ophthalmology because the patient is there for DKA, but they probably have hemorrhage in their retinas from poor diabetic control. And that may be something you as the ICU physician may pick up. Other things in terms of direct trauma would be a patient who was in a bar fight, was in a car accident, or some other form of accident, may have bruising to the retina, and oftentimes you would see external findings, or they may even be comatose. So we need to take a look at the back of the eyes, and worse, could be a retinal detachment or a complete break in the eye, which is technically a scleral rupture. It's technically an open globe. However, it's so far posterior, closer to the optic nerve, we cannot access that in order to close those. And again, optic nerve injuries, neuropathies, transections, swellings, and things of that nature. So, open globe injuries, we talked about, need an emergent closure. You really want to recognize it so that we can close the organs. Things you can look for, the pupil may be peaked. You may actually see a subconjunctival hemorrhage that goes 360 degrees. So even if the conjunctiva is intact, the sclera may not be intact. Or in some cases, you may see the iris or other structures of the eyes being expulsed from the trauma. So this was something that I used, that I found and I've used before talking about some eye trauma. And this is just demonstrating, in this case, is a baseball, but anything that can hit, you can see it coming. And here you can see the eyeball and you can see how when this hits the eyeball, you see how much that eyeball completely compresses. Because the orbit is all bone, it may break, but you don't have a lot of space and energy is never lost. It just gets transmitted. So here we've got mechanical injury and mechanical energy that the eye has to absorb. And when it does, it literally explodes the eye. And so that's an open globe injury. Here is a corneoscleral laceration and something you may see in your ICU. The patient may be completely incapacitated. And in this case, you can see a subconjunctival hemorrhage. This photo is courtesy from one of my professors in my residency. And you can see a corneal laceration, another corneal laceration, another corneal laceration. And here you can see expulsion of intraocular contents where the iris is coming out to sort of plug the wound. So a patient like this, after you got them stabilized, they would be going down with us to the operating room in order to close the eye. And here is a patient who's got subconjunctival hemorrhage. They have a hyphema that's very large everywhere. So this patient, we would be highly suspicious that they've got a rupture of the globe somewhere. So if this patient was found down, nobody witnessed it, or they came in after an accident, we would also want to do imaging of their brain and manage them along with the ICU. So this is a photo of an open globe that I was trusted to take care of, and there is that big laceration and the intraocular contents that is spilling out. And this is just post the end of the surgery, and that's what we would do: put sutures across, try and reposit all of the tissue that we can safely reposit, and then we would hope for the best, that there's no infection and for a good outcome for the patient. Just doing a quick time check here. All right. This can occur after trauma directly to the eyes. And here you can see this is the retina. This is a textbook photograph that I put in. And here there's a horseshoe retinal tear. Think about the fact that if that tear isn't recognized or treated in time, it can keep pulling up and essentially pull up a lot of the retina. And also under here, there is a fluid starting to go under the retina. So not just this can pull up, fluid can get under the rest of the retina, and that could lead to a retinal detachment. This is what you would do in order to treat the patient. So if we saw the patient, if they couldn't even go out of the ICU, sometimes you can bring a portable laser and put laser all around. So I think about it, or I explain it to my patients. I say, think about if you have wallpaper and there's water behind it. I don't have a way to go in if I'm not going into the eyeball right now, to push that water out and put new glue down. We can't glue the retina down. It's neurosensory tissue, but that's how I explain it. What I can do is put a row of laser sort of nail guns all around, so that that stays localized in one place and doesn't affect the rest of the retina. This is a photograph that demonstrates a large retinal detachment. And in here, there's a representation of a tear. So similar to what I was saying, this can keep pulling, but fluid can get underneath and it can keep going. And if not caught early, it can pull off all of the retina. This is a photo of the back of the eye that demonstrates retinal hemorrhages, and this is where ideally this person would have gotten their best vision, but that is being affected, and there's swelling in the retina tissue. And this is a photograph of trauma. This patient actually had an ice pick hit their eye. So a patient that may show up in your ICU, but the ice pick went through the eyeball and actually trapped parts of the retina in there as well. This is a patient who presented after trauma to the eye, and you can tell the pupil is irregularly shaped. There's blood in the front of the eye. And this is what the back of the eye looked like. They have a retinal hole where they would get their best vision to decrease vision, and they've got swelling all around. Doesn't look as impressive. It's impressive for us when you look at it, but this is how scarring started to happen. The optic nerve started getting pale. There is scar tissue, and in the long run, this is what ended up happening. Pale nerve, and then there's all of that scar tissue directly into where they'll get their best vision, so very poor visual prognosis. Lastly, we talked about optic nerves. I'm going to do a quick time check. I have 2 more minutes to stick to time. And in this case, in particular, you can see that there's swelling of the optic nerve. And so that is something that we can always come take a look for you in the ICU, and can help direct management for treatment for a patient. There's also something if you got a direct ophthalmoscope and you went to take a look in the back, you could see, and this can be suggestive of elevated intracranial pressure. This could be secondary to metabolic issues, could be secondary to meningitis, could be secondary to other forms of trauma. So many different things. So the eyes truly are the window into the body, into the soul. And some patients that look like this may not be awake or alert enough to be able to say that vision is altered or anything else of that nature. So treatment for these findings that we just went through and some demonstrative photos is really prevention, prevention, prevention as best as we can, but patients have trauma and get injuries. Identification is key. If the patient can tell you they have pain before you have to intubate them, or changes in vision when they first come in, again, looking at the pupils, looking for the corneal clarity, changes in the shape of the iris or the pupil, or if you see visible blood or visible pus, that hypopion that we showed earlier in the eye. Looking from your end, is there a loss of a red reflex? Do you feel any step up? So you touch around their eye, which would be suggestive that there's a fracture. Before the patient gets intubated, or if they're even a little bit awake, or if you can wean their sedation, do they have limitation of their extraocular motility? Oftentimes, we don't do a patch in the eye when there's anybody with direct ocular trauma. We put a shield, which is more of a metal cage around it, just so that we're not putting any pressure in the eye, and really immediate ophthalmology intervention, and of course, educating the patient about what the risks are and what the expectations are. 1 more minute. And so a quick summary of some of all that we've talked about. So for eyes in the ICU patient, really they all need a multidisciplinary care. We want to triage and figure out if this is secondary to what we have needed to do for the patient in the ICU, or is this something that comes in primary? And do we need to bring ophthalmology on board really early? In the secondary case, we really do need to come up with a protocol for exposure keratopathy that we can deploy all across all our ICUs at home. And for the primary, really ophthalmic consultation for co-management sooner than later. I want to thank everybody so much for the opportunity to speak. I really tried to stay on time and to honor everybody's time. And I'm incredibly grateful for this opportunity. Thank you again.
Thank you very much, Dr. Eniolami Dosunmu, for a very interesting discussion. Before we open the floor for questions, I'd just like to go through what we heard. Dr. Dosunmu spoke about anatomy of the eye with emphasis on cornea, conjunctiva, and back of the eye. And she told us about primary and secondary ophthalmic findings, where she emphasized that the secondary were more critical. She spoke about exposure keratopathy And the fact that in ICU patients, due to the fact that they are sedated, intubated, sometimes have neuromuscular drugs in, they may have issues with blinking, and that could lead to so many other issues like abrasions, keratitis, and ultimately vision loss if not properly taken care of. Thereafter, she went ahead to talk about the protocol for eye assessment, where she suggested that in her center is done every 8 hours, and that the treatment of part of the treatment includes lubrication. Normal saline may not be very good because it easily disappears because doesn't have the same constitution with tears. So we went on to talk about moisture chambers, antimicrobials, contact lenses, and all the rest, and ultimately the need for an ophthalmic consult. She emphasized the fact that prevention is key and early identification is also important, from reports of pain, changes in vision, in pupils, and all of that. And then in assessment of the eye, she spoke about triaging. She spoke about use of direct eye, which could cause different changes in the pupils, swinging flash reflex, and then another assessment procedures. And ultimately, she summarized by saying the eye care in the critically ill involves multidisciplinary role with the ability to triage and determine which is primary or secondary. All right. So thank you, Dr. Dosunmu. I hope I've been able to summarize what you told us over 40
Yes,
minutes.
Ma, thank you so much.
All right, so the floor is now open. I'm going to take the questions in the chat box. And if you have any, please lift your hand and you'll be recognized to speak. But let's start with the ones in the chat box. Okay, many people are appreciating you for an excellent lecture.
Thank
the first
you.
question here is, what is the safest inspired oxygen concentration to be given to a neonate of less than 30 weeks and less than 1,500 grams to prevent retinopathy of prematurity?
So
Again,
thank you.
just a minute. Is there any pathognomic feature we should look out for during bedside fundoscopic assessments?
I will ask for clarification for the pathognomic feature. Are you talking about for the premature babies or are you talking about for adults?
For the
To answer
premature.
the first part of the question, we typically want, it depends on when they're first born. Because right now we keep babies 21 and 5 alive, where I currently have the privilege of practicing. But usually very early in life, they're trying to keep that oxygen saturation at the max of 92, 93. So really 88 to 92, 93. And I would also want to defer to my neonatologist here at work with to give you more directives on what they do. There's been a push to see if they can extubate a little bit sooner. So really go from intubation to CPAP, to nasal cannula, or to high flow first and then nasal cannula as soon as possible. So there's less high concentration FiO2 patients going into the lungs. But every baby and every preemie is really different. So there's really not like this is what we're going to do for every baby. We look at each child and they try and titrate based upon everything else that they're finding in the baby. So really having a good bronchopulmonary dysplasia team or pulmonologist who's a neonatologist also co-managing is really helpful. But the goal is as soon as you can, decreasing the FiO2 as best as you can for the baby.
Okay, the second part of the question, please. Is there any pathognomonic feature?
So for ROP, if we're talking about preemie, there isn't. The baby has to be screened by ophthalmology early. By the time you see something that would be suggestive, it's typically too late. For adults in your ICU, it's looking at the pupils to see if there are any pupil asymmetry or any pupillary reflexes that are not normal. It's also looking to see if the cornea or the conjunctiva has any of the findings we discussed early. And if you're concerned that there is an intracranial process that has not been diagnosed or one that needs optimization of treatment, getting a fundoscopic examination of the optic nerve is really helpful. Between all of those, looking at the reflexes, looking at the pupils, looking at the red reflexes to be clear, looking at the pupils and looking at the conj, the cornea, you generally oftentimes get an idea of what you need to call ophthalmology for.
All right, thank you. The second question, in order to prevent keratopathy, is it advisable to commence topical artificial tears on all critically ill patients without an ophthalmologist consultation?
I would say it is advisable if the resources are available. Sometimes the amount that you need to put in and how often there may be a resource issue. So that's why there was the recommendation to assess patients. Are they closing their eyes? Do you see any exposure? So I would say if a patient fully keeps their eyes closed all the time, or every time a nurse does a scheduled assessment, then maybe no, there's not a need. But as long as you can guarantee the eyes are always closed and there's no oxygen or there's no air going there. But if there's not, then yes, I would say absolutely it is the safer route. And, if I had my way and if we had all the resources available, I would say every critical care ICU patient should just automatically get lubrication on board because most end up having their eyes open. There is not a place for using topical steroids for keratitis as prevention. Steroids actually decrease the ocular surface, the immune response, and increase the risk of getting infection. So I would say steroids should never be used without ophthalmic consultation. Sometimes we will use them to treat people who have an infection after the primary infection has been treated and we're treating other things, but it's never the first line treatment for an infection. Empirical treatment for for keratitis is a broad spectrum. So personally, I like polytrim drops or polysporin ophthalmic ointment. You can try ofloxacin or ciprofloxacin just because of their coverage. Moxifloxacin, trade name is Vigamox, is also another good one as a starter, just because you get that broad spectrum coverage. And then if, of course, the patient isn't responding, or if so in the case of the ulcers, like we demonstrated, we would culture that before we started treatment. That way we can tailor down the medicines we're giving.
Okay, next question, please. Which set of ICU patients require ophthalmology review without any visible eye issue?
I think there are a number. The ones I would highlight would be a patient who has, let's say, comes in, was found down. There's unclear reasons. If you've done neuroimaging that is suggestive of intracranial findings, that would require ophthalmology review. In particular, you could ask your ophthalmologist to check for optic nerve changes, which may or may not explain some intracranial findings. In young children, sometimes we will come into the ICU if there's a concern for a genetic disorder, if the patient comes in seizing or has something interesting that we cannot medically explain. Sometimes an ophthalmic finding may be helpful. Also, patients who have certain metabolic findings would also benefit. For example, we talked about the patient who may be in DKA. If they have a high A1C, you would want onboard ophthalmology to know if there's anything else going on in the back of the eye. So those are some quick examples I can think of.
Thank you. What's your recommendation on eye care for a patient with severe ARDS on prone position in the ICU?
Yeah. So I think that one is usually a little tricky because even that persistent position, you worry if they're going to start having optic nerve issues. I would say as best as you can, if they can get to be in the supine position, that'll be helpful. Although, of course, we know they need to be in that position for a long time. You would want to lubricate them scheduled because in that position is really hard to evaluate their eyes. So from an ocular surface perspective, lubrication, lubrication, lubrication. You would also want to make sure that somebody is doing a good pupil exam, just to make sure nothing is changing because if there is a change. And I would say as soon as you can clear them for dilation, where you feel they're in a window where you're not using a pupil exam to follow them, then I would have ophthalmology take a look in the back of the eyes, in particular looking at the optic nerves to make sure that they've not had any time of hypoperfusion from that prolonged prone position that they may have been in. Additionally, it would be really important if they're in that position for a long time to make sure we're keeping their blood pressure high enough so that they can have good perfusion to the ophthalmic artery.
Thank you. What's the recommendation? Sorry, I've taken that. Does keratopathy affect reliability of optic nerve sheath diameter assessment? And what are the contraindications for this assessment?
So keratopathy ideally does not affect the reliability of being able to measure the optic nerve sheath. Usually the best way to measure the optic nerve sheath diameter would be on imaging. You can look at the optic nerve retinal nerve fiber layers through using an OCT in patients with terrible ocular surface disease, so like a really horrible corneal scar or some swelling or a bad infection that can limit the view to the posterior pole. But if you're able to dilate a patient and even if they're intubated and move them around, provided the cornea is not fully opacified, you should be able to still get an assessment of the optic nerve. If it was fully, completely opacified, using a B-scan ultrasound with a probe set for the eyes is another way for us to look at the optic nerve within the globe and also to look in the retroorbital space to look at the optic nerve diameter to see if there's suggestion of optic nerve sheath dilation, which may be suggestive of other optic nerve diseases.
And then finally, from the chat box, how do you examine the eye in patients with cataracts?
So we usually will check a vision, we'll do a pupil exam, we would do a slit lamp exam. A direct ophthalmoscope can also be helpful, just looking for a red reflex to see if you see one or not. And then we would do a fundus examination as well. So we would then categorize how dense that cataract is, and that would determine whether or not the patient needs surgical intervention to remove the cataract, or if we can optimize the vision by giving them an updated glasses prescription.
Thank you. Someone's hand is up. MD Khan UPTH, you have the floor, please.
Okay. Yeah. Good evening, senior colleagues and colleagues, and good afternoon, Eniolami.
Good afternoon, sir.
Good to see you again.
Thank you, sir.
Good to see you again after the PAGA conference in Lagos.
Yes, sir.
And what is
Your name, please, so that we know, because he just reads MD Khan UPTH. Your name.
Okay, Dr. Nathaniel, Dr. Nathaniel.
Okay.
And I'm an ophthalmologist.
Okay, thank you.
Okay. Yeah. Thank you for that very lucid presentation.
Thank you, sir.
My own concern would be, for our colleagues who take care of a critically ill patient in the ICU. And from my experience, I know that hardly do we receive consults, except for maybe surgical critically ill patients. For medically critically patient, except for those who are probably diabetic, we do have sparing consultation. So I want to actually appeal to our colleagues that looking at this topic, which is very, very good, we just have to divide it into the medically critically patient and the surgical critically patient. For the surgical patient, I know that mostly consultation will come if there are associated ocular trauma. Most likely we do have consultation. But for those medically patients, I think consultation should be done early, even if there are no obvious ophthalmic changes. It's good for us to have this early consultation to actually assess the patient, considering the fact that especially those patients on ventilations, it's good for us to have that early assessment that will help in preventing and possibly prevent possible problem for vision. I've had a couple of patients who have been in ICU, And by the time they were discharged, that was when they were asked to come to the ophthalmology clinic. And by then, there are some damages that already be occurred. And so you now start struggling to try to reverse some of those changes, try to restore the vision. And those. So my take and my suggestion to this noble society is that for every patient that is being managed in the ICU, especially those in coma, I know that most of the times those in coma, early ophthalmologic consultation should be done for those patients so that we can be able to detect those the coexisting comorbidity and possibly the iatrogenic changes that may occur following management in the ICU. So that's basically what I want to say. Once again, thank you, Eniolami, for that wonderful presentation.
Thank you so much, sir.
Okay, I think that brings us to the end of the question and answer session. Over to you, Dr. Irene. Thank you, everyone.
Thank you so much, Moderator Dr. Rosemary Nwokorie, CMAC of General Hospital Asokoro, Abuja, and a core member of the just concluded I-CCSN AGM and scientific session in Abuja. That was a major, that was excellently planned. Thank you so much. I would use this time before I hand over to Mr. President to thank our presenter, Dr. Eniolami Dosunmu. It's I can assure you that you've sparked a lot for us, and I am sure my colleagues, we disturbed the ophthalmologists. So now that Dr. Nathaniel from UPTH has said more, I hope you people will respond promptly to our consults, because for ICU, of course, the whole patient is really important, and the eye is the
Absolutely,
window,
absolutely, we will.
to the body.
Yeah.
So I would like to thank Dr. Dosunmu once again for such an amazing presentation, and we hope that she will, whenever we call, she will respond to us, and we would like to present this certificate of appreciation, recognition
Thank
of
you,
your
ma'am.
presentation on August 2026. This is signed by Mr. President and the Education Committee Chair. Thank you so much.
Thank you so much, Ma, and thank you for the kind invitation. It's an honor to sit in the midst of all these giants here. Thank you.
Thank you so much. In same vein, we would like to sincerely thank Dr. Rosemary Nwokorie. We understand how difficult, it is to carve out time to moderate this session, to have time to do this for the society. We understand that you may not have
Thank you. Thank you.
after the AGM and all the stress, but I sincerely appreciate. And so this is appreciation for your moderation on the 16th of
Thank
August,
you.
2026, signed by the President and myself. And we really wish you, so much as CMAC of General Hospital at Asokoro, Abuja. I will hand over to, I would also thank everyone. I've put in the recognitions quite. I hope I haven't forgotten anyone. Members of the society, senior colleagues, and members of the Education Committee and the executive, our friends, ICN, please come and join I-CCSN. Check our website. Please try and join I-CCSN. We've put the website there. It's not just for anesthetists and intensivists. specialties in medicine, in surgery, ophthalmology, obstetric and gynecology. Please check out website, reach out to us so you can be part of the society. I'll humbly hand over to Mr. President.
Good evening, everyone. Irene, your network is poor. Irene, I want to recognize Dr. Irene. Yeah, Dr. Irene. Irene, thank you very much. Thank you. I don't know network whether it's over there from my own side. Thank you very much, Dr. Irene. Thank you, Dr. Eniolami and Dr. Nwokorie. Thank you as very senior colleagues, Professor Bibio Shinaike, Professor Obashino Gumbi, Professor Christy Mato, Professor Fola Fakmonle, and very Elumelu, and several others who have spared their time to be here. And then the ophthalmologist colleagues, it's interesting to hear Nathaniel talk about the need for ophthalmic consult. I think after this presentation, Dr. Emila, has she gone? Has she left?
I'm here, sir.
Yeah, I think to make it much more effective so that this effort you've made now will not be in vain.
Yes, sir.
Dr. Irene will meet with you and then we'll see if we can draft a small guideline for eye care in the ICU, and then we can actually share it to all ICU units in the country. I think that will be useful. That would be like starting a protocol for eye care in the ICU.
Yes, sir. Thank
so
you
that
for
we will not spare your ophthalmologists, let them be part of critical care. I mean, when the topic came, people will be wondering what are ophthalmologists coming to do in the ICU. Now it's very obvious that they have much more to do in the ICU than staying and be doing only just nerve blocks and then do your fundoscopy. So we have so much work to do together. Thank you very much. We are very appreciative of this effort. I think it also assists us, scout for more Nigerians in the diaspora who are so much more involved in clinical care so that we can learn from what is happening over there. Then we'll be able to at least improve our services to our patients back home.
Yes, sir.
Thank you, everyone.
Thank you, sir.
We hope to invite you next time. Have a nice time. Thank you, everyone. Good night.
Good night. Thank you.
Thank you very much. Just a little announcement. We will have our next webinar on ECMO. I know a lot of us are wondering why ECMO. We're having a lot of private hospitals has been able to offer this, and I prefer, or even before we go for further specialization, at least we have some background on ECMO, and we have our presenters are well in ECMO, young and vibrant. So please, we will send the notifications out, and it should be nice. We all join. Dr. Jedri, please, any other announcements? PRO.
Yes, ma. Thank you very much, ma, Dr. Irene. Thank you very much, ma. This is to just
my
remind
system
us
seems
of
to be
our.
acting up. I can't see any
Yes, your network is not so good. No problem, ma. So is once again to remind us of our annual dues.
Please, are there any other announcements?
Yes, ma, I'm online. To remind members of need for their annual due, please let's make the payment on time. Also, we are starting preparation for the next AGM, which the Congress has agreed that will come up in Lagos. A lot of other things going to come up around the AGM as we continue planning for it. I think those are the two major announcements. We also need to know that paying our annual due give us the opportunity for dual membership of the European Society of Critical Care Medicine, and also afford us a lot of other opportunities that the society has been able to secure for us. It's actually can be a stepping stone to us advancing our career in critical care. Please, let's endeavor to pay our annual due and get fully involved in the society program. Thank you very much. Hello, am I audible? I think with
Yes.
that we can successfully bring the meeting to close. The president has given his speech, and also the chairman of the educational committee has given their speech. Once again, we appreciate you, ma, for your wonderful presentation. And as the chair of educational committee has said earlier, we are hoping that when we call on you again, you'll be available to us. We are actually looking at ways to bring many of you back home. Even if you can't come physically, the knowledge you are impacting will go a long way to actually help our people at home. Thank you very much once again. I join other people to appreciate you for the wonderful work you've done and you are still doing. Thank you. Do have a lovely day.
You too.
Yes.
Thank you so much for the opportunity and for the invitation. Have a great day, everyone.
Bye.
Thank you. Thank
Bye-bye.
you. Bye-bye.